This conference will now be recorded.
Hello everyone, welcome to CM Dental Academy. It's an online dental education platform in the field of dental surgery. We aim at delivering excellent quality online training programs and courses for dental students under the guidance of eminent mentors. The subjects will be covered in all the formats such as live lectures, descriptive notes, MCQs, and Viva Voce questions. So, what are you waiting for? Come, let's begin a journey towards success. In today's orientation class for dental histology, I'll be dealing with an overview of oral tissues. In this section, you're going to have a brief idea about what all you will be studying under this subject. Let's begin with the introduction. The oral cavity contains two types of tissues mainly: the hard tissues and the soft tissues. Hard tissues in the form of bones of the jaws and teeth, and the soft tissues being the mucosa, which lines the oral cavity, and the salivary glands. The tooth has two parts mainly: the crown and the root portion. The crown portion, which is covered by the enamel, it appears white in color, while that of the root is covered by the cementum, which is embedded within the tooth sockets. So, what is the clinical crown? It is that portion of the tooth which is visible in the oral cavity. The tooth is suspended in the sockets of the alveolar bone by the periodontal ligament. So, this is the connecting bridge, the periodontal ligament, between the tooth and the bone. The anatomical crown. It is the crown which is covered by the enamel and the root by the cementum. The periodontium. It is the supporting structure of the tooth. Cementum, periodontal ligament, and alveolar bone. They together forms the periodontium. The innermost portion of the crown and root is occupied by the soft tissue. It is called as pulp. You can see here the outermost covering, which appears white in color, is the enamel. After enamel comes a layer of dentine, and the innermost portion is the pulp. It is a soft tissue component. This forms the crown of the tooth. While that of, in case of root, the outermost covering of the root is being the cementum. After cementum comes a layer of dentine, and into the canals of these roots there will be presence of pulp. So the pulp in case of crown portion is called as coronal pulp. In case of root, it is called as radicular pulp. The dentine occupies the region between the pulp and enamel in the crown, and between pulp and cementum in the root. Development of tooth. In this chapter, you will be studying the phases in the development of the tooth, how it occurs, what are the reaction going to take place to form the tooth, what are the anomalies associated with the tooth, and why they occur. That all the mechanism you are going to study under this chapter, that is the development of tooth. The type of dentition, mainly the primary dentition, the permanent dentition, how do they occur, everything. The tooth is formed from the ectoderm and ectomesenchyme. Now, you all must be familiar what the germ layers, mainly the ectoderm, mesoderm, and the endoderm. Likewise, the tooth is formed from the ectoderm. When this ectoderm comes in contact with the ectomesenchyme, it is nothing but the embryonal connective tissue. There begins the formation of the tooth. Enamel, the outermost covering of the tooth, which is the hardest tissue of the body, it is derived from the enamel organ. Now the question arises, what is the enamel organ? When the fetus development begins, it differentiates into various structures to form the particular organs of our body. Likewise, whenever it forms the primitive oral cavity, the cells of the oral cavity first differentiate into an enamel organ. From this enamel organ, there is a formation of the enamel. There are sequence of reactions like epithelial and mesenchymal interactions take place to determine the shape of the tooth and the differentiation of the formative cells of the tooth and timing of their secretion. These three important factors like epithelial mesenchymal interactions, the differentiation of the formative cells of the tooth, and the time of the secretion determine the development of the tooth. So, what are these formative cells of the tooth? Ectomesenchymal cells, which are close to the inner margins of the enamel organ, differentiate into dental papilla. From primitive oral cavity, first there is a formation of enamel organ. The inner lining of this enamel organ leads to formation of dental papilla. It is a structure. And from the outer lining, it leads to formation of the dental follicle. These two structures, the dental papilla and the dental follicle, being very important, as dental papilla further leads to formation of dentine and pulp, while thereof dental follicle gives rise to cementum, the periodontal ligament, and the alveolar bone. So the enamel is formed from enamel organ, dentine and pulp are formed from dental papilla, cementum, periodontal ligament, and alveolar bone are formed from dental follicle. These are going to be the very basic Vivaos questions. The structures derived from the cells, the formative cells, usually these end with the blast. So it is very easier to remember the cells which synthesize the hard structures, such as amyloblast form the enamel, odontoblast they form the dentine, cementoblast cementum, and the osteoblast bone. Why these are called the formative cells? Because they involve mainly in the protein secretion, which helps in laying down the matrix of the hard tissues. That's why these are also called as synthesizing cells. The prominent features of these cells being well-developed ribosomes, rough endoplasmic reticulum, Golgi apparatus, mitochondria, vesicular nucleus, which is often polarized. These cells helps in synthesizing the hard tissues of the oral cavity. Once the tissues are formed, how they are going to be destroyed, damaged due to any caries or other pathological conditions. There comes the villain. The class cells are called as the resorbing cells, such as osteoclasts resorb the bone, cementoclasts involved in resorbing cementum, and the odontoclasts, these resorb all the dental tissues. The class cells have the similar morphology to the multinucleated giant cells. The name only suggests multinucleated, means multiple nuclei. Giant, it is bigger in size. So these class cells resemble the multinucleated giant cells. Their ultrastructural features include numerous lysosomes and many ingested vacuoles. Dentine is the first hard tissue formed in the oral cavity. Do not confuse not the enamel, though it is the outermost covering of the tooth, dentine being the first formed layer of the hard tissue. Once the dentine is formed, then the layer of the enamel is deposited. The junction between the dentine and the enamel is called as the dentino-enamel junction. The formation of the enamel occurs towards from dentino-enamel junction towards the outer surface, while that of the dentine deposition occurs inward, that is towards the pulp cavity. First, in case of enamel, incisal or cusps are formed, and then it comes down to the cervical region. This is how the formation or the deposition of the enamel occurs. Dentine formation is also similar, but from dentino-enamel junction towards the pulp cavity it occurs. The cementum formation occurs after the form, size, and shape of the root is outlined by the epithelial root sheath. The formation of enamel, dentine, and cementum takes place in phases or in increments. Means there is a daily deposition of some increment whenever there is a formation of enamel, dentine, or any hard tissue is occurring. So there will be gap in between these two increments because there will be a rest after the deposition of the increment. And this gap leads to the formation of the incremental lines. These are almost incremental lines are seen in all the hard tissues. Dentine and cementum formation. How it occurs. First, a bed of uncalcified matrix is laid down. This same matrix later undergoes mineralization. This is the broad two steps which explain how the dentine and cementum are formed. But in case of enamel, first enamel matrix or a bed of matrix is laid down. This matrix first calcifies, then it undergoes maturation or complete mineralization occurs. That is in the secondary phase. First matrix is laid down, the same matrix becomes calcified, then further it undergoes mineralization. What happens during the mineralization? Result of supersaturation of the calcium and phosphorus occurs in the tissue fluids. The formative cells concentrate the minerals from the calcium phosphate and secrete them into the organic matrix in relation to specific substances like collagen, which attracts which attracts these molecules and helps in mineralization. The mechanism of mineralization is quite similar in all the hard tissues. Now, individually, we can study all the hard tissues and soft tissues of the tooth and its supporting structures. Enamel, it is the hardest tissue in the body, derived from the ectoderm. It is mainly formed by all the hard tissues, not only the enamel, dentine, cementum, as well as alveolar bone. They are formed by organic and inorganic components. In case of enamel or inorganic component being 96% by weight in the form of calcium phosphate. These calcium phosphates are formed into the hydroxyapatite crystals and they are arranged in the form of rods. All other hard tissues of the body, such as dentine, cementum, and bone, they also have the hydroxyapatite crystal as the principal inorganic constituent. These hydroxyapatite crystals differ in size and shape. As in case of enamel, it is hexagonal in shape and they are the longest. These are deposited into the enamel rods. It is the only hard tissue which does not have collagen. Compared to other hard tissues, dentine, cementum, and alveolar bone, they have collagen. So you can see here a hexagonal shape of a hydroxyapatite crystal in the diagram. And this is the picture of a tooth, showing the enamel, outermost covering. Then comes the dentine, pulp cavity, the root canals with the cementum, blood vessels, and bone. Enamel does not have any viable cells, means once the complete thickness of enamel is formed, the enamel forming cells, the blast cells, they degenerate. So what will happen? The cells forming the enamel degenerate. Once formed enamel is for the lifetime. There is no further formation of the enamel throughout the life. This is of clinical importance as enamel is lost after the tooth has erupted into the oral cavity and if it undergoes any trauma or dental decay or any age-related changes, the enamel cannot be formed again. Enamel lacks not only the formative cells, also it doesn't have any blood vessels and nerves. So whenever you are excavating the enamel caries, there will not be any blood oozing out. Neither patient will complain of pain when you drill into the enamel. but it is permeable. What is a permeability? There will be exchange of ions between the tooth and the saliva. Using this permeability helps in fluoride ion diffusion from toothpaste into the tooth, which helps to make teeth harder and resistant to dental caries. After the layer of enamel, there is a layer of dentine. It forms the bulk of the tooth. It is mainly formed of dentinal tubules. How enamel is formed of enamel rods. Dentine has dentinal tubules. It also contains the cytoplasmic processes of the odontoblasts. Dentinal tubules are nothing but the cytoplasmic processes of dentine forming cells. Those are the odontoblasts. These are laid in the calcified matrix. The walls of these dentinal tubules are more calcified than the region between between the two dentinal tubules. The apatite crystals are in a plate-like shape and they are shorter, while in enamel they are hexagonal in shape and longer. Dentinal tubules near the pulp are broader and compactly packed. A junction between the enamel and dentine is scalloped to give mechanical retention to enamel. Here you can see a scalloped enamel and a dentine, which are fused together by the scalloped junction between, which is called as the dentino-enamel junction. This scalloping helps in providing a retention form. It can withstand the masticatory forces, occlusal forces. Dentine is also avascular. There is no any blood supply to it. But nerves are present in the inner dentine. Means the dentine which is close to the pulp has the nerve innervation. Therefore, whenever the dentine is exposed by loss of enamel and stimulated, there will be a sensitivity. But not unless like an enamel, dentine forms throughout the life without any stimulation or as a reaction to an irritant. The cells that form the dentine, the odontoblast, lies into the pulp, not in the dentine. The cytoplasmic processes of these odontoblasts extends into the dentinal tubules. Thus, dentine protects the pulp and pulp nourishes the dentine. They form a dentine pulp complex and function as a single unit. The picture showing on the right side, can see here the diagram of a pulp horn illustrating architecture of the large central nerve trunk and the vessels and the peripheral cell-rich zone and cell-free zone of the pulp. So this is enamel, dentine with the dentinal tubules, and this is the pulp with the pulp zones of the pulp, central innervation, blood vessels, and the nerves. This is a diagram of a odontogenic zone illustrating odontoblasts. These are the roughly rectangle cells, the odontoblasts. Their cytoplasmic processes extending into the dentine, and these are the zones of the pulp. The parietal layer, the cell-rich zone, which has the cells, cell-free zone, devoid of cells. These are the odontoblastic nucleus and the odontoblast layer. This is the junctional complex, can see here, the predentine and the odontoblastic processes. The odontoblast along with its cell-free zone and cell-rich zone together they forms the odontogenic zone. Innermost layer, that is the pulp, it is the only soft tissue of the tooth. It responds to the stimuli in the form of pain. It contains odontoblasts. It also has pool of undifferentiated ectomesenchymal cells. These cells, the undifferentiated ectomesenchymal cells in the pulp, has the capacity to differentiate into any blast cells whenever there is a requirement. For example, whenever there is a damage to the dentine, the undifferentiated mesenchymal cells from the pulp differentiate into odontoblast and causes the repair of these dentine. So this is a protective mechanism. The pulp is continuous with the periodontal ligament through the apical foramen or through the lateral canals. So this is the coronal pulp and the radicular pulp. It also contains defense cells. The average volume of pulp is about 0.02 cubic centimeter. This is the very important fiber question. The defense cells present in the cell, also the volume of pulp. The hard tissue covering the cementum is called covering the roots is called as the cementum. Okay, the cementum organic and inorganic constituents are approximately similar to that of bone, but not exactly the same. The cementum covering the root meets the enamel covering the crown. Where they both join together is the thinnest portion. And the cementum is thickest near the apex of the root. That is the root end portion, it is thick, and towards the enamel end it is thin. The cementum is attached to the periodontal ligament fibers, and like dentine, cementum also forms throughout the life to keep the tooth in functional position. The cementum is the hard tissue which binds with the periodontal ligament and helps in maintaining the tooth in the sockets throughout the life. It forms as a repair tissue in excessive amount. The cells that form the cementum are called as the cementoblasts. These cementoblasts line the cemental surface. Uncalcified cementum is usually seen at the superficial layer. Because cementoblasts line the cemental surface, they lay down this uncalcified matrix. The cells within the cementum, once it is formed, they are present in a spaces called lacunae. These are called as the cementocytes. And the cytoplasmic processes of these cementocytes are called as the canaliculi. The cementocytes are not present throughout the cementum. They are limited to the particular area. The cementum with cells is called cellular cementum. Without cell is called acellular cementum. Acellular cementum's function is mainly to providing the anchorage to the tooth, while cellular cementum provides adaptation. Like dentine, cementum also forms throughout the life and is also avascular and non-innervated. This is a picture of a cellular cementum showing the cementocytes present within the lacunae. Above there is a fiber of periodontal ligament. This is cellular cementum with the cementocytes. These are the cytoplasmic extensions of the cementocytes called as the canaliculi. They are present in a lacunae. The supporting structure, the periodontal ligament, it is a fibrous connective tissue which anchors the tooth to the alveolar bone. The collagen fibers of the periodontal ligament penetrate alveolar and cementum. That's why it helps in supporting the tooth. They usually run a wavy course. Periodontal ligament also has the formative cells, mainly of bone, osteoblasts and cementoblasts. In addition to these two, it also has the fibroblasts and the resorptive cells, osteoclasts. Cementoblasts are very rare. Usually in health, they are absent, cementoclasts, which resorb the cementum. The fibroblast also function as resorptive cell. So, two types of resorptive cells present in the periodontal ligament, one being the osteoclast, which resorb the bone, other being the fibroblast, which have the formative as well as resorptive function, dual function. So, this is a picture of a fibroblast, which are stellate shaped present within the periodontal ligament. Thus, with the presence of both formative and resorptive cells of the bone, connective tissue, along with the wavy nature of the fibers, the periodontal ligament is able to adjust itself to the constant change in the tooth position, and it also maintains its width. The periodontal ligament connects all teeth in the arch to keep them together, and it also nourishes the cementum. Along with this, it also has the presence of proprioceptive nerve endings provides tactile sensation. It also has the pain receptors, which responds as a pain whenever there is a occlusal masticatory forces beyond its bearing capacity. So why the pain is elicited? It responds in the form of pain. This is a periodontal ligament photograph. Can see here the bone, the alveolar bone, and the periodontal ligament having a blood vessel, presence of blood vessel, and the cementum with the numerous fibroblasts present in the periodontal ligament. Alveolar bone. It is present in the form of alveolar processes of the jaw that forms and supports the tooth socket. It develops during the tooth eruption. Once the teeth are exfoliated, and these alveolar processes resolve. The basic structure of the bone is very similar to that of bone elsewhere found in the human body, and also it shows the presence of immature bundle bone. So how it is formed? What is the structure of a bone in the oral cavity? It is present in the form of maxillary bone and the mandibular bone. How the maxillary bone differs compared to the mandibular bone, which is more dense? What is the trabecular pattern? This all you will study under this alveolar bone chapter. It is formed of two compartments, mainly the buccal cortical plate and the lingual cortical plate. In between these, there is a cancellous bone. The arrangement and density of the cancellous bone vary in upper and lower jaw. The ability of the bone, but not the cementum, ability of the bone to form under tension and resorb under pressure. This mechanism of the alveolar bone is used mainly for the orthodontic treatment, for the movement of the teeth. That's why you need to study these all hard tissues, how we apply them clinically in patient's treatment. This is the alveolar bone proper, consisting of a bundle bone, the concentric lamellated bone. There is a Haversian canal with the Haversian system, presence of lacunae. This is a layer of a dentine, a layer of cementum, and the bundles of the periodontal ligament. Temporomandibular joint. This is the only movable bilateral joint in the skull. But why you need to study about this? Because the joint movement is intimately related to the presence or absence of the teeth, and the joint's function means the absence of the teeth and the presence of the teeth, any anomaly associated with teeth, all are interrelated to the functioning of the joint. If anything is disturbed between these two, it will spoil the equilibrium or the harmony between the oral cavity and the joint. It has a fibrous layer that lines the articulating surface, which is continuous with the periosteum of the bone. The fibrous capsule which covers the joint is lined by the synovial membrane. Maxillary sinus. The maxillary posterior teeth are related to the maxillary sinus because they both have the common nerve supply, and their roots are often separated by a thin lining. Injuries to the lining, the maxillary sinus lining, and extension of infection from the apex of the roots of the maxillary molars, usually which are encountered during the clinical practice, are the factors to be taken into consideration. Developing maxillary canine teeth are found very close to the sinus. So, precaution has to be taken, such as the proper diagnosis and the investigation, such as radiographs are mandatory before extraction of maxillary posteriors, usually to see the sinus lining. The maxillary sinus is usually lined by pseudo-stratified ciliated columnar epithelium. If you encounter a damage to the maxillary sinus during the extraction, there will be a communication between the oral cavity and the maxillary sinus, which leads to formation of a oroantral fistula, which is of a clinical significance. To avoid this, it is mandatory to take the needed precautions. So after studying all these structures like enamel, dentine, the pulp, periodontal ligament, cementum, alveolar bone, the temporomandibular joint, maxillary sinus, the most important factor being the eruption and shedding of the teeth. How the teeth erupts into the oral cavity. You have that you're going to study under this chapter. Once they erupt into the oral cavity, like primary teeth, there will be exfoliation or shedding of the teeth. What is the mechanism involved? How do they are exfoliated? That all will be dealt in this chapter. The eruption is highly a programmed event. Teeth developing within the bony crypt initially undergo bodily movement. So what is the bodily movement? The teeth moves, tooth moves. Tooth and crown both move in one direction. That is the bodily movement. Then it shows the eccentric movement. Eccentric is not along any specified axis, not placed centrally. It shows these two movements. Make it appearance into the oral cavity. At that time, the roots are about half to two-thirds complete. When the crown formation is complete and root formation is complete, almost to half or two-thirds, the teeth start showing bodily and eccentric movements. Just before the tooth makes its appearance in the oral cavity, the epithelium covering the tooth above will fuses with the oral epithelium. The epithelium covering the tooth above undergoes degeneration sometimes. So it makes a way for the eruption of the tooth, which is a bloodless event. There are a sequence of events how this all occurs. I have just briefed you the important points here. What exactly happens? The factors involved in eruption of the teeth being the root growth. There has to be almost two-thirds of the root formation complete. Once it is complete, the fluid pressure built at the apex of the erupting tooth. That fluid pressure helps in movement of the tooth towards the occlusal plane. Also, the dental follicle, the formative organ of cementum, periodontal ligament, and alveolar bone. It imparts the contractile forces on the tooth. These three factors contribute to the movement of the tooth towards the occlusal table. The deciduous teeth are replaced by permanent teeth. This being as an adaptation to the growth of the jaw and due to the increased masticatory force of masticatory muscles. The permanent successor teeth during the eruptive movement cause pressure on the roots of the deciduous teeth. This also is a contributing factor for the movement of the tooth towards the occlusal plane. This is only applied to the deciduous teeth and induce resorption of the roots of the deciduous or the primary teeth. This is the cause class. Tissues play very key role or an important role in this mechanism. Similar to the osteoclast, participate in this event and has the capacity to resorb all the dental hard tissues. Oral mucosa, very important structure in the oral cavity. The mucosa lining the mouth is continuous anteriorly with the skin of the lip, that is the vermilion border of the lip, and with posteriorly till the pharyngeal mucosa. Thus, the oral mucosa and gastrointestinal tract mucosa are in continuation. It is attached to the underlying bone or the muscle by a loose connective tissue. Below this oral mucosal epithelium, there is a loose connective tissue which helps in adaptation to the bone. That layer is called as the submucosa. But in certain areas, such as the hard palate and the gingiva, the mucosa is directly attached to the bone. Such mucosa is called as the masticatory mucosa. The mucosa in these regions is a functional adaptation to mastication. That's why it is called masticatory mucosa. Elsewhere, except in dorsum of the tongue, the mucosa is loosely attached. It helps in adaptation to allow the mucosa to stretch. And this mucosa is called as the lining mucosa. The stratified squamous epithelium varies in thickness and is either keratinized, like in case of the masticatory mucosa, or it is non-keratinized, like it is in lining mucosa. The submucosa is prominent in lining and nearly absent in masticatory mucosa. The mucosa that attaches the tooth is unique, it is thin and permeable. The fluid that oozes through this mucosal lining around the crevice of the tooth is called as the gingival fluid. This fluid is of clinical importance because it prevents the entry of bacteria through this epithelium. The mucosa of the dorsum of the tongue is called as the specialized mucosa because it has the taste buds in the papillae. This is a picture of an oral mucosa showing the epithelium with all the layers of the epithelium and the connective tissue. The epithelium and the connective tissue are separated by the basement membrane here. Okay. And the connective tissue component, that is the lamina propria, shows the blood vessels, the vein, and the nerves, and the deeper submucosa shows the presence of minor salivary glands with the opening duct. Here, the epithelium shows all the layers of the epithelium, like basal layer, the prickle cell layer, the granular layer, and the corneal layer. This is the basic structure of the oral mucosa. And also, there is a presence of bone. Salivary glands. You all must be aware the names of the salivary glands and how they are present, how many are present. Broadly, salivary glands are classified into two types, the major salivary glands and the minor salivary glands. Major ones occur in pair, being the parotid, submandibular, and sublingual glands. And the minor salivary glands, they are present usually in the submucosa, everywhere in the oral cavity, except in the region of masticatory mucosa, that is hard palate and anterior hard palate and the gingiva. They secrete serous, mucus, or mixed secretions into the oral cavity. It depends on the particular type of the salivary gland. They have a peculiar secretions, and few have the mixed secretions. The connective tissue, which contains nerves, blood vessels, and lymphatics, they divide the gland into few compartments, and these are called as the lobes, which further divided into lobules. The acini, which are the production centers of salivary secretion, are of two types, mainly the serous acini and the mucous acini. This is a schematic presentation of a typical salivary gland with the serous acini. Here you can see a serous acini. Okay. Serous demilunes presence here. And in case this is the mucous acini with the demilunes. This is the intercalated duct in cross section. Then comes the striated duct, which empty into the large excretory duct. So from the secretions from this serous and the mucous acini, they will be expelled into the intercalated duct, then to the striated duct, then to the major excretory duct. This excretory duct directly opens into the oral cavity and expel the saliva into the oral cavity. This is the mechanism how this glandular structure works. They vary in size, shape, and also the mode of secretion. It depends on the acini. In this chapter, you will be studying what is the serous acini, what is the mucous acini, which all glands show the serous, mucous, and the mixed acini, the composition of the saliva, the mechanism of secretion of the saliva, and also the salivary gland, the abnormalities or in disease condition, what will happen, age-related changes. These all will be included in this chapter. The ducts not only acts as the passageways for the saliva, but they also modify the composition of the saliva in regard to quantity and electrolytes. The ducts which vary in their structure from having the simple epithelial lining to the advanced stratified squamous epithelium lining, which shows the functional modifications. Lymphoid tissues and lymphatics of orofacial region. The tissues of our body are bathed in the tissue fluid. It contains diffusible constituents of blood and waste products discarded by the cells. Majority of the tissue fluids return back to the circulation through the veins, but 1/10 of the secretions are carried by the channels called as the lymphatic channels, and the fluid present in these channels is called lymph and passes through the lymph nodes. These are the small bean-shaped organs occurring in groups. They function to filter the foreign substances in the body. The tonsils are the similar lymph organs which acts as the guard at the entrance of the alimentary and respiratory tracts against the antigens which come in contact with them during eating and breathing. Lymph node contains two different zones. In its maturation of two different lymphocytes occur, mainly the T lymphocytes and the B lymphocytes. It also contains variety of defenses. The lymphatic system consists of primary lymphoid organs in the form of thymus and bone marrow, secondary lymphoid organs in the form of spleen and lymph nodes. The enlargement of lymph nodes is of clinical importance as it occurs in response to an invading organism or due to tumor cells entering from the draining area or due to the tumors arising in lymph node itself. That's why we need to know any abnormality, any disturbance, or any disease in the oral cavity leads to the enlargement of the lymph nodes, where it is drains or associated lymph nodes. What are the lymph nodes? What is the structure of the lymph nodes, levels of the lymph nodes, or the types of the lymph nodes? All you're going to study under this topic. Once the tissues are formed into the oral cavity, what will occur in them as the age advances will be dealt here. The tissues of the body undergo certain changes in microscopic appearance as well as in their function, and these are called as the age changes. Enamel, it will be lost due to physiological, mechanical, or chemical action, resulting in exposure of the underlying dentine. So once dentine is exposed, it shows the sensitivity. Deposition of the calcium salts occur throughout the certain regions of the dentine, making the roots appear transparent, which is called as the sclerotic dentine in case of dentine. Pulp shows areas of calcified bodies, and these are called as the pulp stones. These are the age-related changes seen in enamel, dentine, and pulp. Cementum shows increase in the thickness, especially at the apical third. Periodontal ligament shows decreased in the number of the cells. Alveolar bone undergo resorption. In case of oral mucosa, thin, the papillae of the tongue it becomes thin, papillae of the tongue are lost, and the mouth becomes dry, decreased secretion of the salivary gland. The person experiences gradual loss of taste sensation due to depapillation. The attachment of the gingiva to the tooth shifts apically, resulting in the recession and exposure of the more of the clinical crown into the oral cavity. So far, the study of the oral tissues, mainly the hard tissues and the soft tissues, we have dealt with now. What all we will be studying under those chapters? How to study those tissues is of importance. So, for light microscopic examination, the tissues have to be thin sliced and stained. Teeth and bone, usually they can be ground or can be decalcified before making them into thin slice. In case of ground sections, all the hard tissues can be studied. But when they are decalcified, all the hard tissues except enamel, pulp, and periodontal ligament can be studied. Soft tissues of the mouth require the similar preparation as that of the soft tissues of the other parts of the body for microscopic examination. For traditional light microscopic examination, the tissue have to be made into thin sections and differently stained by utilizing variations they exhibit in their biochemical and immunological properties. There is no only one standard stain and one standard method to study all the tissues. The staining and the method to study the tissues differs based on their biochemical composition, even the immunologic properties. So to study individual cell at microscopic level, few methods have been applied, like histochemical, enzyme histochemical, immunohistochemical, and immunofluorescent techniques. It is based on the tissue cell requirement. So to study specific cells, specific methods have to be used. Apart from this light microscopy, electron microscopes can also be used. These are the more advanced versions to study the tissue at the very minute level. Other than this, there are fluorescent microscope, confocal laser scanning microscope, and autoradiography techniques for better recognition of cellular details, functions, and the series of events that take place within them. So these are the advanced methods used to study the individual cells. So these all the structures along with the all the hard and the soft tissue structures present in the oral cavity along with the methods to study them, you are going to study in this dental histology subject, a very interesting subject, so that you will have the detailed thorough knowledge about normally what is present in the oral cavity. So CM Dental Academy has formulated a course for the entire dental histology subject in this format, such as the live online lectures, which will be conducted during the evening hours as the convenience of the students. Immediately after the lecture, the access to the recorded lectures will be provided on the website. The descriptive e-notes will be provided to particular chapter. Once the chapter is over, MCQs pertaining to that chapter will be released. Even the Viva was key points. For the chapters such as the salivary glands, oral mucosa, or the pulp, periodontal ligament, alveolar bone, the slide discussions will be conducted. What all will be the slide, which are the components present in the slide, everything in detail, the structures present in the slide, so that it will help you in identification of the structures and detailed knowledge about the structures. So slide discussion, these will be conducted separately at the end of the chapter. Once the entire syllabus for the university exam is completed, targeted revision will be conducted per chapter. A free Telegram group for discussion. You can clarify your doubts anytime in the free Telegram group by posting it so that you will get the answers or clarification for the doubts. Per batch, Limited seats will be taken so that all the students will be benefited. Registrations have already begun and course will commence from June 1st. So grab the opportunity and book your slots. What are you waiting for? Come, let's begin a journey towards success. This is upcoming event by the CM Dental Academy, the orientation class on dental anatomy, which will be on 27th of May at 7 p.m. Thank you.
This conference will now be recorded.